So this is a structured Viva task assessing information gathering, communication with patient, communication with colleagues, patient safety, and applied clinical knowledge. The examiner will discuss with you the management plan for Hannah Emerson, a 39-year-old who came seeking fertility. She had all investigations done confirming ovulation. However, she has been found to have multiple subserous and intramural fibroids. Recently, she had a diagnostic hysteroscopy which has confirmed a normal endometrial cavity. So, um, so that's a case of subfertility and also fibroid. So it's like a combined case, can come in either module. So first of all, we need to take a full history from the patient. So what data from the history we need to know about this patient? First of all, we need to know whether she has any other complaints, like any bleeding, any pressure symptoms, any abdominal pain or pelvic pain at all. um, like if she has like any problem at all suggesting that this fibroid causing any symptoms. Okay. And she's seeking fertility, so we need to know um, whether it is a primary or secondary, whether she has any pregnancies before or no, and since how long she's seeking fertility or trying for a baby, and whether all investigations also done for her partner or no. Okay. Coming to the gynae history, we need to know full gynae history about this case. So first of all, we need to ask about her menstruation. When was her last menstruation, and what about her? Can you tell me more about your menstruations or menstrual pattern? How heavy? How frequent? Is it associated with any kind of pain? Any intermenstrual bleeding? So then the pain itself, we need to ask about any pressure symptoms, like any pain inside your pelvis, any pain while you are passing urine, any bowel problems, any pain during intercourse, um, any pain during the periods, like sometimes this fibroid may cause congestive dysmenorrhea. So all kind of pain we need to ask about. And we need also to ask about infection, because this is a fertility case. We can't ignore like presence of PID before, or any adhesion, or sometimes because this patient may be having hyperestrogenemia because of these fibroids. Do you know that she is hyperestrogenic lady, so she may be associated with some endometriosis or adenomyosis or whatever. So we need to know about her uh, like history well. um, any previous history of sexually transmitted infection, any previous history of uh, PID, what about her smear history? So all of the questions in the medical in the gynecological history should be asked in this case. Coming to obstetric history, uh, we just need to know whether she has been pregnant before or no, because if she got pregnant before, we need really to know what was the outcome of this pregnancies, because fibroid itself, even with a normal cavity, can affect the outcome of pregnancy. So because it may affect the blood flow to the uterus itself, so sometimes it may cause like first or second trimester miscarriage. So sometimes she may have like recurrent miscarriages, and she's coming now seeking pregnancy. Sometimes it may cause like preterm labor, um, because of, like, even if it is not involving the cavity, but it causes irritability of the muscle fibers of the uterus, if she's getting intramural fibroid, and that will cause also preterm labor. So we need to know about her previous obstetric history if she has any pregnancies. Um, Later on, we need to know about her medical history as usual, if she is otherwise fit and well, any family history of concern, and any surgical history if she has any other or previous surgeries, if she's taking any regular medication, if she has any allergy, and also we need to know about her blood group and any objections regarding blood transfusion, because any lady with multiple fibroids can bleed at any time. And the social history, smoking, alcohol, and recreational drugs, also important, because she is fertility case. We need to exclude all of these like special habits. um, because she is a fertility case, we need to include two additional items in her history. First of all, we need to know about her partner. We need to know about his age, whether he's fit and well, any medical problems, any previous surgeries, like, to know more details about her partner. And that's very important, because sometimes the patient doesn't have any problem, but maybe her partner is diabetic and he has some issues, or whatever, he had a previous surgery in the groin area and it affected like the transportation of the sperms. So we need to know more about the partner, if he is a smoker, using any anabolic steroids, for example, or anything like it which may affect her the fertility. Okay. And we add the other item, which is the sexual history. So we can just signpost to the patient that we may need to ask so private questions, um, but it's really important to know more about it. So we need to know how frequent they have intercourse, whether the couple are aware about the ovulation period or no, and like how long they have been trying, any problems at all, any pain, we need to know about that as well. So that's all information needed from the history. We need really to examine her, we need to have a general examination, because if she is getting heavy periods or bleeding, she may be having anemia, so she may look pale or having palpitation or symptoms of having any sort of anemia. And then we need to examine like her abdomen, uh, to feel the uterus, sometimes you may feel the subserous fibroid as a pelvic mass, and to see whether it is palpable, tender, or no. um, and then we need to do a speculum examination on her, just to rule out any fibroid polyp or any problems in the cervix, whatever. And then we will go for the discussion. So what is the management? Do we need to do anything for that lady? Because she has just multiple fibroids which are not coming into the cavity. The cavity is normal, she has good ovulation, and she has done all the investigation. So why do we really need to treat this patient even if she is asymptomatic? So you know even if the fibroid is not involving the cavity, as I told you, it will affect the blood flow to the uterus itself. So it may cause impaired implantation. Okay. And also they from the pressure from the intramural and subserous fibroid, there may be abnormal sperm migration, because it's not the real pathway or the normal pathway for the sperm, because of the pressure from outside here and there. So it may affect the pregnancy. And it also has impact on pregnancy if it happens that, like, it can uh, it can cause like first trimester loss or second trimester loss. It can cause also pain during pregnancy if degenerations happen or any complication happen during pregnancy, most commonly degeneration. Also, it can cause preterm labor. As I told you, the intramural fibroid will affect or cause irritability of the muscle, and also the very, very important risk of lady to get postpartum hemorrhage if she got pregnant and has multiple fibroids. So the best thing is to deal with it before pregnancy. This will improve the outcome of pregnancy as well, and the incidence of pregnancy rates will be high. So what are the treatment options for a lady with multiple fibroids seeking fertility? So generally the treatment for fibroids can be either medical or surgical. Yeah. So medical treatment including hormonal treatment, okay, and progesterone, continuous progesterone, like Mirena coil, um, or any long-acting progesterone. But if we are dealing with a case who is seeking fertility, this hormonal or long-acting hormonal treatment will not be suitable for her. So we are searching for a surgical treatment. So what are generally, not this case, what are the surgical options for a lady with multiple fibroids? Uh, so if it is a single fibroid, we will do myomectomy and that's it, okay? Or if it is coming into the cavity, like if she has submucous fibroid, we will do a hysteroscopic resection. But she has intramural and subserous, and it is multiple fibroids, so we need something to affect the whole uterus. So she has a choice of hysterectomy, which is not suitable for her, and uterine artery embolization, which is the most appropriate management for her. Why that? Because uterine artery embolization will not affect her fertility. If we remove the uterus, that she will not be able to get pregnant. If we do myomectomy, we will just do myomectomy for 1, 2, 3, 4, and if we do for everything, we will leave unhealthy uterus. She can't be pregnant on that uterus. So the thingy is to block the blood flow to these fibroids, to be shrunken in size spontaneously, and then leaving uh, like you know um, a healthy uterus with a less number of fibroids. So the benefit from offering this lady uterine artery embolization is that it can cause reduction of the fibroid number and sizes, and also this we will avoid having a big surgery like hysterectomy, and we preserve her fertility, okay. But it sometimes carries risk, and that's why we need to really inform the patient about them. First of all, risk of infection, because we just block the blood flow which is going to the fibroid, and we will leave it to degenerate spontaneously. So this degenerated fibroid, the fibroid is a bloody uh, like a bloody growth. So this is a very good environment for the bacteria to grow on. But that's only if the patient is having low immunity or prone to have infection, or if she has already infection previously in her vagina or pelvis, a transmitted infection. So that's why we need to exclude her risks in the history. That's why we asked that question in the history. um, so this is the risk of infection when we have the degenerative fibroid infected. So we need to instruct the lady to report any symptoms suggestive of infection, like if she has any like if she felt unwell at any time, or she spiked any temperature, or she showed any foul smelly vaginal discharge or anything like that. Okay. Sometimes one of the complication is damage to other organs, which may be possibly the ovaries. Why is that? Because sometimes, you know, the ovaries blood flow, it comes from the ovarian vessels, but it also takes some like, you know, sharing or anastomosis with the uterine vessels as well. So sometimes, you know, unfortunately, when we do the uterine artery embolization, the ovaries will become ischemic, and they will not get the enough blood supply, and unfortunately the patient may enter into menopause because of this treatment. Is less likely to happen, but we need to inform the lady that this is one of the complications that it may happen, and that's because disruption of the ovarian blood supply. So how we do uterine artery embolization? It's actually being done by interventional radiologist, or um, you know, a consultant gynecologist who has a special interest and the training to do this procedure. Um, so the patient will go on a specific day, like an elective procedure, and we will use what we call the fluoroscope, which is like, you know, a device which produces X-ray beam, but it's a live X-ray. We see things moving on a monitor, and the patient will have, like, we call it conscious sedation. When we give the medication to the patient to give her some relaxation and you know, less feeling of the pain, but she will still be awake. We call it conscious sedation. Okay. And then through the femoral artery, we make a small incision, and you know, we put a catheter inside the femoral artery, and the radiologist will guide it till we reach like one of the uterine arteries. And once we reach the uterine artery, the radiologist will inject, like, you know, a contrast dye, which usually contains iodine. So why we ask about allergy in the beginning? We need to see whether this lady is having any allergy to any contrast or any iodine containing components. Okay. So why why the radiologist will inject this contrast? This contrast will go through the uterine artery and, like, you know, allow the uterine artery and its branches to be visible on the screen or on the monitor, like, you know, we call it uterine artery mapping. So it will draw all the branches, and then we will see where exactly the blood vessel going to the fibroid, and the fibroid will shine on the screen. So once we diagnose the fibroids and their blood vessels, then we will insert, you know, a very very tiny particle of gelatin or gel foam to block this artery, and then again we inject the contrast dye and see whether the fibroid will get any more bloods after we inject this gel foam or no. So just to confirm that we have blocked the artery correctly. So once we have done one side, we will go to the other side, and both sides can be managed with the same incision. Okay. So we'll do the second uterine artery with the same maneuver, and that's it. So the problems, because we already blocked the blood supply to the uterus, if this patient got pregnant later on, so there is a very very small risk of placental insufficiency, because now we reduce the blood supply to the uterus, so the blood flow to the placenta will be subsequently reduced. This is a very small risk, but we need to tell the patient about it. Another risk, the risk of uterine rupture here is little bit higher than expected, because we cause ischemia of the myometrium. So with the contractions, it's very weak and ischemic, and it can easily rupture. So these are small possibilities if she get pregnant, but yeah, we just need to inform her. And don't forget to inform her about the small risk of going into menopause, and that's how we manage this case. Okay, so usually before we go ahead with uterine artery embolization, we need to do an MRI. That's very very important. We can't go ahead for uterine artery embolization without MRI. Why that? Because we need really to be sure about the sizes of fibroid, and whether these fibroids getting like enhancement, um, like on any contrast media or anything like that, because sometimes very 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 small, like possibility that it is not leiomyoma, it can be leiomyosarcoma, and we don't detect it. So once we like confirm this is the best option for her, we need to send her for MRI just for confirmation that it is a benign fibroids, and then we will go ahead for the treatment. Okay, any other modalities of treatment will not suit our case, because she's seeking fertility. Usually at this age, if she is a primary infertility and she didn't have any pregnancies before, after she has this uterine artery embolization, we can refer her to fertility center if she's trying for a long time, just to help her with any assisted reproductive technique will be the best option for her. Okay.